Just a first comment, how incredibly awesome is it that at the end of workforce research data, we have farm animals? Pretty incredible. I'm trained as a physician assistant and a pharmacist myself, and have worked in geriatrics my whole career. Grew up in a rural community, so so much of what you say really speaks to me personally. I'll give you one little anecdote before we jump to Q&A. So I have two grandparents in South Carolina who have both suffered sort of chronic illnesses, which is not uncommon among well-fed Southerners. Lovely people, public school educators, and probably for the last 9 years they've been homebound, sort of medically ill. And I went home in the midst of our planning for the session, and I just counted up how many home care workers those two had, and I could go back for 6 years. They've had 78 different home care workers in their home. So it's not generalizable data, but I just share with it because the context is there are individuals that are dramatically influential in the health and the life of our patients and our communities, and what are we doing to support and understand and collaborate with them. So thank you both for that data. Let's stop and take about maybe 15 or 20 minutes. I think before we blast you with too much data, I want us to have a chance to synthesize and also benefit from the expertise in the audience. So how about let's offer some time for Joanne and Aaron for some discussion and questions from you, if you're willing to do that.
Yeah, Susan Scrimshaw, former co-chair. Having observed actually this, again with elderly parents, but also working in home settings, one of their issues with training in terms of a wide range of things for home care workers, I think this has just been fascinating, and it includes things, of course, like detecting risk, detecting problems, but I think back to something like occupational health. I mean, I saw a home health worker injured because they didn't know how to lift somebody. And this is something you get taught in PT, OT, and nursing, and the whole range of nursing care. So it's something that goes both ways. In addition to the fact that these people are doing a tremendous amount of very valuable work, there's risk to them. And it is critical for them to be able to identify when they call in somebody else and say, I think you need to look at this person, or I need your advice, or whatever.
Yes, I absolutely agree. There was a project that my colleague Susan Chapman did with somebody from PHI a few years ago where they looked at training requirements for personal care aides. And there is a companion, basically the short answer is not many states have any training requirements, and they're often inconsistent across programs. So there might be one requirement for children beneficiaries and another one for adult Medicaid beneficiaries. So there's a lack of consistency. But they profiled some leader states that have tried to create rational systems. And I would say at this point, Washington State is probably the most interesting one to look at. They have a career ladder. It was essentially kind of a joint arrangement that the union was very involved in and working with the state government. The state government believes it is going to save them money in the end to ensure that there's training, pay a better wage, that you earn more money as you attain additional specialization and knowledge. And they expect lower emergency department visits, fewer hospitalizations, fewer institutionalizations. The evaluation data are just coming back that are starting with just safety is good, but they really are hoping that over time it's going to prove to be not only a way to get better jobs and better respected jobs and less occupational injury, but also get better outcomes and cost savings for the state.
Thank you. Inga Corliss, I'm a nurse. Oh, sorry. Inga Corliss, I'm a nurse, so I wanted to speak to the education of students. And I don't think it's a preference necessarily for acute care settings. We also educate our students in community and ambulatory care settings. I think it's how do we provide supervision? And so we're going to have to look at other ways of doing that if we want to do it in individual homes. We can't have one faculty member go out for each home. We have to look at simulation and other models to be able to do that. But I don't think it's necessarily. You can have the preference for acute care. It's how do we educate students to provide safe care.
Yes, thank you. I think that's a really important point. And you've raised in your comment a couple of critical issues, I think. One is we recognize in looking at the workforce that one of the things we lack is actually good ambulatory settings, so model settings where we can put nursing students or home settings. So that's one issue, is it's actually easier to sort of find acute settings and put, so part of it is how do you inventory and find out these community-based settings? You know, I was really struck by the data as I was collecting it, is that we're going to keep moving care, and if we're going to keep moving care, we're going to have to really up the ante in finding these sites, right? So that's one important point I think you raised. The other issue you raised is around faculty, which I think is absolutely critical, is, you know, making sure that we have the faculty who can actually be preceptors and work in these settings. And then a third issue, which you sort of alluded to, but you didn't actually specifically say, that I'm going to put words in your mouth with permission, is another issue is that regulatory bodies have pretty specific regulations about who can oversee the nursing education process. And so if I'm in public health and I'm trying to give nursing exposure to public health, you know, do I have to be supervised by a nurse, or can I be so the questions I think are that you're raising are critically important. And I think at the end of this workshop, it'll be very important to think about the multidimensional aspects of, and it relates to nursing, but it could be pharmacy or any other health profession as well. And how do we sort of tackle these multiple elements? So thank you for that question.
You highlight a couple other comments, too, I think, in the book that was shared about the potential disruptive impact of technology in education. The other that sort of comes to my mind is I remember many, many times sort of preparing for an accreditation visit for an educational program I was responsible for, and the fight between making sure we comply with those accreditation standards and then also looking regionally and locally at what we were trying to prepare our students for. I think that's a challenge a lot of us sort of face. Let's take a comment over here.
Thank you for those two wonderful presentations. I'm particularly intrigued by the barnyard model for interprofessional education. But I say that with all seriousness because pictures like that, or memes, however you want to think about it, are really critically important to change things. Because as I reflect on the data, the question I have for you is whether the data is sufficient. The data is clearly more powerful than it was 20 or 30 years ago. But the same sort of issues were raised by the data 20 or 30 years ago. This is not a new issue. So my question for the two data geeks is, how do you move beyond data to really change? Because we haven't changed in 20 or 30 years. And that's really why we're in a bigger mess now than we were 20 or 30 years ago. So I'd be really interested in your thoughts about how to move beyond the accretion of more data, as important as that is. Don't misunderstand me. But it hasn't got us anywhere for 20 or 30 years, so how do we move forward?
We're like, do you want to do that? Do you? You know, I think that the opportunity, and I'll speak as a data geek, is that there are some really powerful model programs that have developed. Right, the Independence at Home program, the work that the VA does if it doesn't get destroyed in the near future. You know, there are other educational institutions. The work that Barbara's Center highlights as much as they possibly can. And getting those out into the world are very important. Now, in addition to being a data geek, I'm an economist, so I'm kind of doubly damned. And that also means, to some extent, the financial incentives need to change. As long as the financial incentives for education are aimed at medical specialties and are making it much easier to do all your education in acute care, that is what we're going to get. We've been doing some work related to California's health workforce, and as we're tracing all of the flows of residency money and education money, I'm hearing things like, yes, we would love to train more of our registered nurses in community settings like assisted living, but we have the faculty problem. And some of those sites basically say, look, there's going to be such a burden on us, you need to pay us to let your students come in. Well, public university or a public community college don't have that money. They just straight out don't. So there is this financial incentive issue that I think we need to address. And I don't want that to be a cop-out, but I think it's another piece of the problem, and we just have not had the will to really push it through.
It's not a cop-out at all. It is one of the potential answers, and it's a critical one. And we need to be talking more about the policy changes needed to reconfigure the financial incentives. And I would hope this workshop would do that to some degree.
Thank you for your question, because it's one, you can't see it, but I'm wearing a little bit of a superhero coat, and I actually call myself a data agitator. I actually take great pleasure in producing data that challenge the sort of prevailing narrative. This is actually a field that I absolutely love. And so for all the professions in the room, I know that I've angered you at some point, and I sort of apologize, but I sort of don't. Because my job, actually, to your question, is to produce data that actually make people uncomfortable and to actually use it and insert it in policy. And so I gave a presentation recently about the importance of using data to tell policy stories and the importance of framing. And so a lot of my work lately has been around using data to frame issues. Let me give you a very real example. And Remer talked about this, is one of my passions is graduate medical education for physicians. If you look at where we have graduate medical education training versus where we actually need physicians, there's not good alignment. And so I put together some data which came out in health services research around what if we actually used data on workforce needs to distribute graduate medical education training dollars? What if we did? That makes people really uncomfortable. And so to Dr. Cox's point, I think it's incredibly important, and we will keep at producing data that make people uncomfortable, and we will keep framing it, and we will keep working in that direction. And I'm passionate about this. And so I think it's really important question, but I think we have to produce data. And if we're not producing those data, you need to ask us to produce it, because we will. So I think that's where I would leave it.
But Erin, it's the agitation that's the important part. Over and above the data. Data itself is insufficient. So I must say that I haven't heard two cogent responses, more cogent than what the two of you have just responded to my question in 30 years. Thank you very much.
Sounds like progress. That's awesome. Let's go to Pam here.
Thank you for the great presentation. Pam Jeffries, Dean of Nursing at GW. I'm sitting here, I was struck by the data and the information, but not surprised. And I'm aligned with what I'm hearing. But the reality is, and I'm going to, what Dr. Corliss is saying again, so as we try to shift from acute care to community, it's really hard. You can have one student here, two students here, three here. And that model that we continue, it's not sustainable. And even if we want to shift from acute care from the hospital, it's just tough. But on the other end, the hospitals now, and I'll just say on the nursing realm, they're starting to charge us. And as a nursing community, we can't afford that. The cost is going to go on to the student. So that's problematic. I know medicine, PA, they pay, they have CMS money, but nurses don't. And just here in DC recently, there was an outlandish cost that was coming to me if we wanted our NPs to use that preceptor model, et cetera. The other piece is our education is, I'll just say nursing education, it's aligned for acute care. We're still by pediatrics, psych mental health. That is slow to change, but one reason it's slow to change because of our accrediting bodies. We still have the NCLEX for the nurses. It's still the blueprint for the acute care, not on community. So that's problematic because you got to teach for the licensure. And third, I think market's going to drive some of this. What's shifting, I'll just speak for the MP. We have a large NP program, so many FMPs, but now hospitals don't want FMPs because now they need acute care MPs in the hospitals, not in the community where FMPs used to be in the hospitals. So that's shifting as well. So I see the market driving. And one last point, palliative care is so important. I'm sitting here by a palliative care physician, and I understand end-of-life palliative care, hospice, all of that. We had a palliative care certificate program. Well, accreditation changed. You now can sit for certification for palliative care without having academic credit or having the big C certificate and taking this. So then that dramatically decreases enrollment on these specialty programs when you're changes because now they can work in hospice for a year or whatever and go sit for certification. The education's no longer required. So that shifts enrollment and who goes into some of these specialty programs. So I just bring that to your attention, my comments. Thank you.
Thank you very much. Let's go here. We probably have time for maybe 2 more questions, but save your creative thoughts because you'll have lots of chances to put them into work.
Thank you both for your presentation. Stephen Chesbrough, American Physical Therapy Association. To Aaron's point, you didn't make me mad, but I had to question a lot of assumptions because it sounds like to me, and it continues to sound like, there are a lot of assumptions that are based on medicine and nursing. When you go back to your slide about the different models, at least from a PT, OT, and speech-language pathology, not only are there no financial incentives that Joanne spoke of, but actually there's some disincentives, right? And so the models that may work or may not work for nursing and physicians, to make the assumption that it would translate to athletic training and others is a little bit of a challenge.
So I'll just respond, which you may know of some recent research that we've done, actually, with Janet Freeberger, who's now at UPMC, and we've actually looked at patients who get more physical therapy services outpatient, and the outcomes are just fantastic, right? So then we say to physical therapists and occupational therapists, OTs were also in the work that I did with Janet, is really sort of trying to figure out how to increase incentives and try to understand why people are getting OT and PT in acute settings, but not getting it as much as they need to in outpatient. So what are those disincentives? So that is exactly an example of us trying to use data again to say we know the outcomes are better for speech, language, and therapy and OT and PT in outpatient. We know that there's some patient-level barriers related to race and income, but we know that there are some system-level barriers, right? And then once we understand those, to Malcolm's point, we agitate and we begin to sort of create data that say, wait a minute, the outcomes could be better, payers would be happier. So we are trying to produce data on that front as well.
Yep, I totally agree that that's a follow the money. And if you look at an organization like Kaiser Permanente, which I am enrolled in, when I blew out my ACL, there was nobody dickering with me about how many PT visits I could have. They had a group physical therapy thing set up for the end game and said, you can come here. Like, I could probably still go and show up right now. But from their perspective, that reduced the odds of my being back in the operating room again.
As panicked as the health system I work for feels these days about the shift of value as an educator and researcher, I say, let's go. Let's go all in to value. How about let's take one more question here. Thank you.
Sure, thanks. Ted Mashima with the Association of American Veterinary Medical Colleges, so I appreciate the barnyard reference. But just for, yeah. And so I'll continue the shout out because in the and I love the inclusion of plumbers, handymen handy people in the list. So I'll argue for the inclusion of veterinarians from the standpoint of 4 points. You know, public health, think about food safety and zoonoses. Think about companion animals as they enhance mental health and encourage exercise. 3, consider the relationship between domestic violence and animal abuse. And the 4th, you find health professionals in rural communities in a high number comparatively to other health professions. But real thank you for that list. I'm going to use that a lot.
So we're going to shift the source of the data a little bit. And if I could ask Chris, thank you.